Please welcome your panelists for the session, Fostering Innovation to Improve Healthcare, moderated by Ross DeVol, Chief Research Officer of the Milken Institute.
But it's good.
Good morning, everyone. For our last morning session, we'll go into the early afternoon. I am Ross DeVol, the Chief Research Officer at the Milken Institute, and I will serve as moderator of this session, Fostering Innovation to Improve Healthcare. Improving health is a core mission of the Milken Institute. We accomplish this through holding convenings such as this, through our research, as well as to our policy recommendations to improve health, not only in the U.S., but around the world, and also do economic analysis of healthcare. This goes from looking at specific diseases to disease groups, from infectious to chronic disease. And we bring together, through our Faster Cures unit, patient advocates, researchers, investors, and policymakers, and we try to remove the barriers, first identify them, then remove the barriers to finding ways to get from the bench to the bedside much faster. So the focus on this morning will be on the delivery of healthcare, looking at innovative solutions to coverage, delivery, and the financing of healthcare. California has a long history of innovation. Probably our earliest innovation was in 1848 when gold was discovered, that the new inhabitants of the state decided to include the Sierra Mountains into the state's borders because there was a lot of gold up there. And also drawing the border southeast until they came to the Colorado River, recognizing a long time ago that water would be important for a very long time. So we have a history of innovation. We have more recent examples of innovation. The Health Maintenance Organization really was pioneered here in California and copied around the rest of the country. And our panelists bring unique backgrounds and perspectives. We had some of the most interesting pre-conference calls I've probably ever had in moderating a panel. So they're all very passionate about this topic. So let's do that. Let's get to the panelists. Let me introduce them. And there still is some forms of discrimination. One of them is alphabetical. So I will introduce our panelists in that order. We have Donald Crane, President and CEO of the California Association of Physician Groups, to my right. Next to Don is Ed Hernandez, Chair of the Committee on Health for the California Senate. Welcome, Ed. We also have Dr. Richard Milken to my immediate left, who is President and CEO of the Heritage Provider Network and for the Milken Family Foundation. I almost said Milken. I apologize. Next to Dick is Kristen Miranda. She's Senior Vice President of Strategic Partnerships and Innovation at Blue Shield, so she should know a lot about this since it's in her title. And last but not least is Art Torres, who is Vice Chairman of the California Institute for Regenerative Medicine, maybe the State Stem Cell Institute, if you will, former member of the California Senate, and also on the board of Covered California Today. So with that, let's get into the discussion. I welcome you all. Kristen, let's start with you. As I said, you have innovation in your title, so I've got to go to you first. You have a big responsibility, and we look at changing the healthcare system from what I sometimes have called moving from a sick care system to a healthcare system, or maybe moving from a fee for service to delivering service-based healthcare and value. What are you seeing in the areas that you're working in? How far are we moving along? And really, can California be seen as the innovator in making these changes?
Well, I think you could argue that we've sort of been on this forefront now for decades, right? And I think certainly Don's organization and Dr. Milken's represent some pretty significant work on that front. I think what I would say, though, is that the model is changing. And I think if you look at what's going on in pockets across the country, we're really seeing some pretty interesting stakeholders come together and start working together to really try to sort of achieve, one version of the triple aim. I think in the work that we're doing, what I think is continuing to sort of be the greatest challenge in moving from that fee-for-service paradigm into kind of a pay-for-value model is hospitals, quite frankly. We've got continued challenges with them. I think they probably, if you look at all the key stakeholders across the country, they probably have got the biggest challenge in terms of making that transition. But I think I think California, you could argue, is probably still at the forefront of this. I think there's a lot of exciting work going on.
Great. Don, let me turn to you. You're head of a very prominent physicians group. How are the health service professionals moving to more of this accountable, coordinated care model? And it's causing some disruptions, I think, but I would say the Affordable Care Act has probably nudged us in that way. But maybe there's another 5-letter abbreviation, MACRA, that people will be hearing a lot more about. Maybe you could let people know just what that might be doing over the long term.
Sure. You're talking about MACRA, the Medicare and CHIP Reauthorization Act that was signed into law just last April. And at least for our purposes, as we talk about innovation in the healthcare delivery model, in my view, far more impactful, frankly, than the Affordable Care Act, which was a big deal for many, many ways. But in terms of the way physicians are paid, and providers, hospitals and physicians, and how care is delivered, this MACRA law is of even greater impact. It's the law that was best known for repealing what was known as the SGR, the sustained growth rate, kind of arcane subject about how the physician fee schedule is developed. And so that was what drew all the headlines. But in the back pages of this law are these new provisions relating to, I apologize, a couple new acronyms, APMs, alternative payment models, and MIPS, I think the Merit Incentive Payment System. Anyway, 2 new programs that almost all physicians in the country and all physician groups in the country are going to have to stare at and make a choice between choosing either the APM route, it's 2 forks in the road basically, or the MIPS route. And both of them lead into much, much higher levels of value and steer them really in the direction of kind of the California model that we've had for 10 or 30 years, really, as Kristen has said, which is towards capitation, basically value-based payment where the amount is always varied by the inclusion of quality metrics and so on. So that law is a watershed law and is giving a big boost to this movement from volume to value that Kristen referred to.
Great.
Yeah.
Dick, let me turn to you next. My understanding is you were inspired by the X Prize, and you created, developed, and funded this $3 million Heritage Health Prize, which really challenged teams to look at predicting who might be in the hospital over the course of the next year. Could you maybe explain to the audience what were some of your motivations behind it and what some of the results have been thus far?
Sure. Well, actually, we've done 5 prizes now. We've done a prize with the National Cancer Institute on best way to handle breast care strategy. And we've also have a strategy and we have an incentivized competition when the White House reached out to us in the Office of Science and Technology. But we're best known for the $3 million Predictive Modeling Heritage Prize. And the way that developed was there's, well, let me put in perspective that there's $3 trillion spent on healthcare in the United States. $3 trillion, and yet in research for the cure at the NIH, there's $30 billion. That is 1%. And most of the healthcare economists will point out that possibly up to 30% of healthcare dollars are misaligned, and particularly in the hospital. So we thought if we could figure out some of that misalignment and we could predict a year in advance of who would be in the hospital, we could transform some of those care dollars, some of those $3 trillion care dollars to cure dollars. We wouldn't be spending less money, we would just be putting money into cure. Right. And so what we did is we vetted it with the health plans, and many of the health plans said that they did some of these things subjectively, but they didn't have very good results. We then vetted it with Microsoft and Intel said, well, it should be 99.99% accurate. And that's pretty good prediction. So we thought that we would do this at 85%, both for sensitivity and specificity. And now here comes the wow factor. We had 39,000 entries from 41 countries. Nobody from healthcare. Stochastic modelers, data scientists, and not even the best, but the top tier were 6 times more accurate than the health plans. And we just found that that was something that could change healthcare in the United States. So that was what motivated us, and those were some of the results.
Truly remarkable. Ed, let me turn to you now. You've been in the middle of a lot of these discussions on expanding coverage and access to health care. The Affordable Care Act has already begun to implement some of these changes, still in the early stages, but some would say it's really disrupting the entire system. What are we seeing in terms of the consolidation of health plans? And could you maybe share with the audience how you see this unfolding so far?
Well, first of all, thank you for having me. With the implementation of the Affordable Care Act, it's the biggest thing that has occurred in the healthcare in this country since the 60s, since the Johnson administration. Of course, California, I'm proud to say that we're in the leading edge of its implementation, with the first having exchange. We're moving forward with Medicaid expansion, all the patient protections that we have. But we as individuals, whether it's hospitals, physicians, groups, entities, whatever, we're creatures of habit, and we're not used to change, but more so change the size that we've just recently had. So there's a lot of unknowns out there. And because of the amount of dollars that you heard earlier that are in the healthcare system, everyone is trying to figure out how it's all working. So what I'm seeing now is a lot of consolidations. Consolidations from health plans. Health plans are now wanting to get into the Medi-Cal market because 1/3 of the population is seeing Medi-Cal, to provider groups, to IPAs. Don's group is growing in leaps and bounds with physicians that are trying to figure it out. And I think if it's going to work, you're going to see the day of the individual, independent Marcus Welby practice going to be long gone, to you're going to see coalitions of hospital systems, to medical groups, to physician groups, to be able to provide better and better quality health care. But also the biggest shift that I think we have to understand is that we have to shift from how we bill for a service to how we make sure that people stay healthy. So yes, there are going to be these consolidations, but here's my concern. My concern with the consolidations, especially if you look in Northern California in the hospital systems, with those systems, because they have a monopoly, they can raise costs. So consolidation is good, but we have to make sure that it doesn't go overboard. And here's where government's going to step in. Prior to the Affordable Care Act, individuals weren't required to have health insurance. We're now requiring individuals to have health insurance, and if they don't, they're going to get fined. And I'll tell you, if the consumer feels that they're not getting their money's worth, they're going to tell their electeds, and government will step in and control cost. So I believe the market needs to play its natural way out, but we have to be very cautious and leery about consolidations, but more importantly, how do we provide a service and care to the public at a reasonable and affordable cost? And I really like what I just heard about some of the predictors for the future. So.
Absolutely. Thank you very much, Ed. Art, let me turn to you. You wear many hats. You're on the innovation of creating new breakthroughs in medical research to finding cures with I'll use the Stem Cell Agency, but also you're on the board of Covered California. And we're still in the early stages of implementing it, but I was really astonished. I'm usually a pretty good predictor. I've been an economist. I made a living predicting. And I would have not predicted the pool that you shared with me that have signed up for Covered California thus far. Could you maybe share with the audience what we're seeing thus far in terms of who's been signing up?
Well, Covered California is basically an insurance company with a 5-member board, 2 of which I worked with 30 years ago when they were in the Governor 1 Brown administration.
Right, yes.
Diana Dooley and Marty Morgenstern. So it's a very interesting dynamic where we have signed up 1.4 million Californians. We've collected about $6.4 billion in premiums. There's still 1 million Californians that need to be covered under Covered California. There's about 2,800 small businesses, and that needs to increase. We have about, I would say, about 12,000 insurance agents trying to sell Covered California, and now beginning the biggest challenge, working with the counties on Medi-Cal. but 37.6% of our members are from the white community, whereas only 26% are from Latinos, Asian Americans 22%, African Americans 2.4%. So we have a lot of work to do still in reaching out to the Latino and the Asian and Pacific Islander community and the African American community. And I think that's going to happen with the initiatives that we have in place, but it's also important to note that the people that are covered, 53.5% are those people between the ages of 45 and 64. So these are people that could not afford health insurance before. They're finally starting to come into the session. By 2016, we'll cover about 90% of the hospitals in California under one plan or another. But again, as I like to call us, the chronologically gifted, we have a we have a responsibility to provide that outreach as we move forward. And I think the biggest challenge is going to be, as Dr. Senator Ed Hernandez, who I'm very proud is the chairman of our Senate Health Committee, has said, we need to look at innovations. And I thought, Mr. Milken, I think that you're doing an incredible job to reach out as to how to make healthcare more efficient. But also, we're going to have to deal with the scarcity of nurses, the scarcity of physicians in rural areas. And so therefore, the virtual reality of bringing pediatricians from San Francisco through television or other social media to children in Delano or children in Fresno who would not have been able to see that kind of a physician before is really the future.
Thank you very much, Art. Let's get into first starting with the kind of expanding coverage and access to health care. How does this really reduce the growth in healthcare costs in the future? So why is it so important to bring previously uncovered people into the system, and how do we tackle those issues? Anybody?
The most important thing is ER utilization. Yeah. And that is going to be the responsibility, as I told the other board members of Covered California, to educate populations out there to switch to the notion that you can see a physician. Don't go to the ER, because we all know what that cost us in terms of care.
Right. Anyone else in terms of people that, a lot of conditions, undiagnosed diabetes, for example, and people tend to end up in the emergency room. Right. If we can intervene earlier, can we really reduce the growth in healthcare costs?
This is more of a social issue than a medical issue. Right. People, change is difficult. People embrace the status quo. You mentioned, how do you bring people into Delano? Well, what I did when we first started in 1979, physicians did not exactly embrace managed care.
Right.
The same people that Senator McCarthy was looking for were the same kinds of people that didn't want to embrace Medicare. And particularly in rural areas, which Central Valley. So we went to Detroit, Chicago in the middle of winter. We waited until the weather was terrible. We went there and recruited. So actually, I brought doctors into Delano.
Well, thank you. Having worked for Cesar Chavez in those early years,
that's exactly
that was
right.
the need.
That's exactly right. So, but I think this is a social issue, and I think more and more social workers will be part of the team, and it will not be just physicians and nurses.
Right.
Yeah. I'd like to follow up on what Art said, and yes, it's a social issue, but keep in mind that this is the law of the United States of America. We have an Affordable Care Act. We have the segment of the population we need to insure, but also the undocumented we need to have a discussion about as well. But let me tell you why it's important that everyone gets insured, but let me also give kudos to Covered California. The big difference between our exchange and every other exchange is we're an active purchaser. And because we're an active purchaser, what Art said, they can act as an insurance company, they can control costs, and they can control their rates. That's really, really important. But why is it important that we insure everybody? What are our biggest cost drivers? Diabetes, high blood pressure, heart disease. Where are they? Central Valley, East LA, Oakland, the poor communities of color. And unless we address that, we're not going to control costs. And the other thing, by having everybody in the system, and once we spread the risk, then costs are going to go down. But more importantly, we're going to have a healthier community and a healthier state and a healthier country. I'll just kind of close with this. I just see patients once in a while. I was talking to Don right now. When I saw patients when I was on break, a third of the patients I saw were new, 90% of them were Medi-Cal, and all of them were the first time in the healthcare system with multiple chronic diseases.
Yeah.
Because of that, we have a much unhealthier population, but once we get that population healthy, it's going to be better, and also healthcare costs are going to go down.
Yeah,
So
but it will take a
that's
while.
it's going to take a while, but that's what we have to work on as
Absolutely
public
right.
policymakers.
Yeah, you know,
Kristen, why don't you share with the audience, you were very early, your organization was in moving to kind of the accountable care, coordinated care model. Maybe share some of your findings thus far. You've been doing it for what now, 6, 7 years early?
Yeah, we have. Actually, we sort of started this as something of an experiment, and we started discussions with a couple of large provider organizations, Hill Physicians and Dignity Health, probably back in 2007. So we weren't calling this an ACO. This was before the passage of the ACA, but we knew that we had to figure out, even in California, even working with some relatively sophisticated organizations who'd been doing managed care in one form or another for 30 years, we were still seeing healthcare costs going up at a double-digit clip, right? It was absolutely unsustainable. We were heading off sort of a collective cliff. And we sat down, and it took us about 1.5 years to sort of get over some of the competitive issues. Dignity Health has a foundation in the market that we were looking to launch this in, and we had to kind of get over some of that. We had to get over some of the sort of cultural issues, but we developed a model that really, at its heart, did a much better job of aligning broad incentives across key stakeholder organizations, and really sort of compelled us to start sharing information in ways that we really hadn't before, really require kind of a level of transparency. And so that we went live with that in 2010. We've got 26 of these now across the state. We have just actually run some of our latest numbers. The first 5 years, we have delivered to our customers essentially $325 million or so in savings. So it's definitely been driving additional value, and we're working with very different kinds of organizations, some of them very sophisticated integrated systems, some of them sort of local physician groups with local community hospitals, and it's really driving some results. We've got a long way to go, though. We're still seeing, even at 5%, healthcare costs going up at that clip is too high. But we've seen some pretty significant movement.
Let me turn to you, Don. What have you been seeing in working with your physicians groups? Are we moving to this accountable care model, and are we seeing adaptation? I mean, there's some reluctance, there's some issues I understand from the physician side.
There's both. I mean, first in California, there's been widespread acceptance of basically managed care and capitation for decades. So that represents well over half of the way that California works. But outside of California, very different situation, where once upon a time there was managed care, and it receded in the 90s and had a stigma attached to it. Coming back now by virtue of the Affordable Care Act and the MECRA law. And there's areas of resistance, you know, over my dead body. I want to be paid fee for service. I want to be paid per click. I want to do more work. I want to make more money. But then there are others that are kind of drinking the Kool-Aid, which is to say, be responsible for the total cost of care under some kind of a budget-based payment system. Could be capitation, could be a shared savings kind of program, much like Kristen's, I think, ACOs are. In multiple ways it can be done, but where the organization, physician group, maybe coupled with a hospital, is responsible for the health of the total population. And when there is savings measured against a budget, it's then distributed to the group in the hospital. That's the sort of new mode of payment model that's underway. Some are embracing it just as a bell curve. I mean, some people are by nature interested in change and doing that. So you see great examples of that popping up in Colorado. There's a number of them. I have a number of new members. And they're doing it with gusto. And in other areas, I think there's resistance.
That's so.
Yep.
And so we're going to watch that play out over the next 6 or 10 years as the nation, basically in a word, pays hospitals and doctors very differently than it used to. That's what's going on.
Art, let me ask this question. There have been some concerns expressed that Covered California's plans predominantly are PPOs, and they haven't offered as many of the new forms of ACOs. Now, first of all, is that accurate? Are we starting to see more offerings of ACOs through Covered California?
Yes, I think it's a matter of, well, historically it's a matter of time. this is still a baby in California and the nation. And I think that as that baby grows up, you're going to see an involvement of much more interaction, at least I intend to, with Ed in the legislature, but also in terms of what we need to create within this model. The model is sound, the model is good, and the federal subsidies that many of the patients rely upon, thank God that's there. Who knows what will happen in a new administration after 2016. I know that I'm going to be deported if Trump is president. And people forget that in 1935, 1 million of us were deported, half of whom were U.S. citizens in boxcars, not with the refugees I worked with in Salzburg last month. But the bottom line is that there are going to be more options available. There are going to be more opportunities available. And I'm excited by the potential that's there, and I want to continue to work with doctors as I did when I was chairman of the Assembly Health Committee eons ago, but also to make sure that we have accessibility to the policymakers, the healthcare plans, so that they have an input as well. And the hospital councils that I've been speaking to, especially in Northern California, we need to involve them more. We need to get their ideas and see whether what they think might work better.
Yeah, I want to just jump in on that, because I will tell you, he's absolutely right. I think that we have not yet made sort of the full range of options available in Covered California. My own organization was sort of part of that. We started and offered kind of a PPO model. And the reason we did that, well, there were a variety of things that sort of compelled that choice, but we weren't sure what this population was going to look like. We weren't sure what kind of price point we were going to try to hit. We were genuinely concerned about taking this new sort of platform and sort of implementing kind of a more value-based model, and not sure what kind of risk that was going to mean really to our provider partners. So we are definitely making our ACO model available on the exchange in 2017, and I think we're going to see certainly a whole lot more of that.
I think you guys are doing a great job.
Dick, did you want to jump in on this?
Just that we are 100% all a full risk HMO for the Covered California.
I'm proud of that.
Yeah, well, Heritage is one of the best in the country for sure.
Okay, you can collect the fee for that later on.
Sadly, what are you going to do? It's true.
You can put that in your marketing campaign. I mentioned this a bit earlier, but I think it's important for the audience to really appreciate this. About 5% of the population accounts for more than 50% of the healthcare dollars spent, and most of those people have multiple chronic conditions. So it seems to me this is the area where we can really make the most progress. And just how important do you see that in terms of moving forward? Are we at a point now where physicians, other healthcare professionals can spend time counseling behavioral modifications, whether it's diet, not smoking? We'll get into what you're doing in that public policy area shortly. But just what are we hoping to see? What's happened so far? Anyone?
Well, between 2010 and 2050, we're going to see an increase from 50 million to 84 million of Americans that are over 65. That is a major problem for us. And when we look at the neurodegenerative diseases that we're looking at in the stem cell agency, whether it's Alzheimer's, Parkinson's, Huntington's, ALS, the biggest cost of the healthcare system is not cancer, it's not heart disease, it's dementia.
Yeah.
And that's something that we're going to have to deal with much more formidably than we have in the past. In 1977, I passed the Long-Term Care Act, which allowed for adult day health centers to be in existence based upon the Unlock model in San Francisco, and it's still operating there. But that was an opportunity to keep seniors out of nursing homes if they were ambulatory, but still a place to go. With dementia increasing, Alzheimer's increasing, that population is going to get worse. And we'll do our share in the stem cell agency, God willing. But at the end of the day, that's going to be the major cost factor for two groups of people. Me, like a caregiver for my 92-year-old mother, may she rest in peace, but also people in my age group that have to take care of their parents. They exhaust their savings. Medicare doesn't take care of it. Medicaid doesn't take care of it. Somebody's going to have to deal with that issue as we move forward.
Well, I'd like to mention that there's 3.2 million people that have hepatitis C. And the new drug for hepatitis C, although it's broadcast that it's about $80,000 or $84,000, with the adjunct medication along with it, it's about $150,000. And if everyone that per year, and if everyone that needed or has Hep C got those drugs, that is more money spent on Medicaid in all 50 states.
It's amazing.
Now, let's talk about Alzheimer's. Currently, there are over 5 million people in today's population that have Alzheimer's. So forgetting about inflation, if Hep C, which is usually or frequently in the lower, in certain demographics, the people that get Alzheimer's are not, will be all demographics. Let's say it's $300,000. So $300,000 times 5 million patients, that's going to really affect the world, not just the United States.
Absolutely.
And I think that's something that people should be concerned about.
No, I'd like to follow up. Obviously, I agree with Art with regards to the aging population. And you wanted to talk about the increased cost of chronic disease and getting to them. Well, there's another segment of the population that's just as important that we need to look at. Yes, Cover California has a lot of individuals in it. Yes, Blue Cross, the open market, small group. But 1/3 of the population here in the state of California is in Medi-Cal. That's a population that I think we need to make sure that's the most vulnerable. The newest patients that come in have the highest incidence of disease, chronic disease. That's how we're going to address it. But here's the problem I see with that, and Art made a point earlier. We have a distribution problem and an access problem to providers, and providers aren't taking Medi-Cal, but more importantly, providers aren't going into Delano, to Fresno, to Oakland, to East LA, to Compton, because of the reimbursement rates.
Right.
If we're really going to solve this, we have to address that. But it's a combination, not only addressing that with reimbursement rates. We have to look at innovative ways how we're going to get more primary care providers, whether they're non-physicians, to be able to see these patients. Because I'll tell you, physicians graduating from medical school don't want to go into primary care.
Right.
They all want to work for Kaiser because they pay a lot of money. They all want to be specialists because they get reimbursed a lot. So the reality is we're going to have to look at innovative ways of how we're going to see this population and address it.
So do we have anybody in macroeconomics in the audience that can help us?
Well,
This becomes an economic issue.
It does,
not a
but
medical issue.
we have to address it, and government has to address it, because if we don't, we're not going to solve this issue, because this is a very vulnerable population.
Just to give you an idea, right now, Medicaid rates, Medicaid is national, the word in California is Medi-Cal, are at about 60% of what the federal government pays for Medicare. So if you're a physician and you're looking at taking care of patients, who you're going to take, you might take care of Medicare patients, seniors, and that amount is considered roughly fair, it's a benchmark. But to take 60% of that, it's not sustainable. So therein lies a huge problem.
It may be fair in some demographics, but if anybody here goes to Manhattan or Beverly Hills or West LA, doctors will not take Medicare.
They won't even take Medicare. So.
And you're asking them to take 60% of something that they would not take.
Yes.
So that's, to me, just as big, if not the biggest problem we're going to have besides the aging population, is we have to figure out how we're going to be dealing with the segment that's most vulnerable.
Are we making progress, though? We're still in the early stages of Affordable Care Act and looking at overall accountability. But are physicians and healthcare specialists able to spend more time with behavioral modification, counseling, whether it's smoking, whether it's diet? Are we starting to see them be able to not just have 5 minutes to give them a quick rundown, but is that part of the system now?
We're making some progress in some quarters.
Still not there yet, though, right?
Well, Kaiser Permanente is a good example where a lot of progress has been made, and some of my other members where they're shifting to a kind of a team-based practice. So less individual doctor in a 15 by 12 room, 28 patients a day, into more a team-based practice where there's the physician, yes, but there's all of the physician extenders, pharmacists, there's the transportation, there's nurses, there's psychologists, and that team is able to take better care of more patients. So there's some progress, but it's small.
Very slow.
It's
Right.
slow.
I think it's
Slow.
very slow. And
Yeah.
I'll tell you, and I think part of it is truly what Ed was getting at earlier. I think it's a compensation issue, right? I don't think that we yet have developed the right mechanisms to compensate providers for taking that extra time, acknowledging what that yields on the back end, right? We've made some steps there, but we're nowhere near where we need to go. The other thing, though, that I think is honestly going on is even with some of the organizations that we're working with now that are, again, relatively sophisticated, have fairly strong infrastructures, they don't all look like Dr. Milken's, right? And many of them are incredibly resource challenged. And so part of what we're sort of looking at now is what steps can we take in addition to sort of aligning incentives on the right way and sort of doing these programs with these organizations to really accelerate rapid improvement or reasonably rapid improvement. We really think that we now on the plan side are going to need to make some real investments in some of these organizations to help augment resources. So I think it's compensation models for sure, and I think it's also augmenting resources.
I agree.
Well, another factor which we need to take into consideration, something I'm working with at UCSF now and Stanford, is end-of-life costs. It's probably the most expensive part of the healthcare delivery system. And if you begin to, the last 6 months is right, and if you begin to look at that more carefully, we're going to have to address palliative care much more responsibly, because there's no way that we can continue to use extraordinary measures and give people the choice. And right now people are talking about, as my Jesuit governor signed the right to die legislation, right to try legislation. People are thinking about it more seriously than we have saying that Medicare or ACA was going to be a death panel. It's about realistically looking at this. And now I think you have the public moving behind this effort to begin to look at palliative care more seriously. And I think that a coalition of folks working on it really has to happen.
A few years ago, there was a study that in Dade County, Florida, and Staten Island, the last 30 days of your life, you were in the ICU 21 days. Oof. In Minnesota and San Francisco, 3 days. Same species, the best that I can imagine. And yet,
Let's hope so.
the care was completely separate.
Right.
Yeah.
Yeah, it is remarkable. Let's turn to public policy for just a moment. Ed, you've been working in this area. I know you've been trying to pass legislation to raise taxes on tobacco. I mean, we've made a lot of success in terms of reducing the smoking rate, but part of this has to be behavioral modification. And speaking as an economist, incentives, or in this case, disincentives matter, relative prices matter. And so how do you see that progressing? Is it going to get through eventually?
So we do have a special session that was called by the governor to deal with two issues, transportation and healthcare, and more in particular, how do we deal with the issues with Medicaid reimbursement and trying to increase that, and of course the waiver and some other issues at hand as well. But with regard to Medicaid, there's been a lot been said, but one of the issues that we're looking at in the legislature is increasing the per pack tobacco tax. So currently California is amongst one of the lowest in the country. We're looking at $2 per tax. Unfortunately, it's going to take a 2/3 vote requirement, which is very difficult. You have obviously the tobacco industry opposing it. But here's the dilemma that we have. If we were to pass that tax, and if we were to increase it by $2, it's estimated to bring in the state of California about $1.2 billion, which may seem like a lot of money. But if we were going to raise Medi-Cal reimbursement rates throughout the entire state of California to equal at least Medicare, the Medi-Cal to Medicare, which is kind of an okay standard, it's going to take about $6 to $8 billion of additional revenue. So it's a small portion that's going to go towards it. To say that we shouldn't do it, we should still obviously try to do it. But if the money comes in, we have to look at innovative ways of how we use that money to incentivize areas, to look at trying to get providers where it's tough to get providers, increase reimbursement rates. We need to look at innovative ways. But also another thing that I've done as well is changing the smoking age to 21. And by doing so, the Institution of Health just did a study, and they found that 21 was the most efficient age. 25 is good, 19 is good as well. But if you were able to get those young individuals, you're now going to get less people addicted to tobacco, but more importantly, less people having complications with asthma, smoking due to smoking, cancer, and we're going to also reduce healthcare costs. When you think about the unintended consequences of tobacco, it's the number one leading cause of death and one of the cost drivers we have in the healthcare system. So those two in tandem are things that we are working in the legislature right now.
Absolutely. Let's turn back to, Kristen mentioned some of the alliances that are developing across different stakeholder groups that some might think are normally competitors. Some might call them maybe strange bedfellows. So is sharing information critical to making this work? And are we seeing progress and more information sharing?
Well, I can start. I think it depends on the organization. I think, again, one like Dr. Milken's probably controls a whole lot of that data, right? I think what we see, for the most part, is an incredibly fragmented, siloed, and fairly manual exchange of information even still. One of the things, and I'm guessing this might be what you were getting to with the strange bedfellows, one of the things that we did about 1.5 years ago is Blue Shield of California and Anthem Blue Cross, which are very fierce competitors, came together and created an organization called CalIndex, which we're sort of envisioning will be, we hope over time, kind of a public utility, sort of a statewide health information exchange. It's very early, and quite honestly, I think our goals are pretty aspirational. It's going to be a very tough slog. But I think the data exchange and somehow getting to a place where a patient's information is accessible and follows that patient regardless of where they move and is accessible electronically is absolutely going to be critical to kind of driving things forward more quickly. It is going to be a very tough slog. But yeah, so that was certainly an unusual arrangement, the two largest plans that compete very bitterly in California coming together. But I think it's just a reflection of we've got to somehow think things through very differently.
Right. Don, what are you seeing in those areas in terms of collaborations that...
It's increasing. Clearly, as a general rule right now, the landscape is characterized by silos and fragmentation. I mean, that really bedevils our California system and contributes to the affordability problem we have. But the exceptions to the rule are happening like a lot. So Kristen's in charge of 27 or more of these quote-unquote commercial ACOs, which are a good example of strange bedfellows coming together, trading partners coming together and sharing data, sharing personnel, and then sharing profits. So that's a cool example. Other plans have examples of that on the commercial side. On the government side, you hear a lot about the Medicare ACOs that are out there. So there's a fair amount of that, and that's kind of collaborative stuff, but we also have a lot of consolidation. So you have hospitals buying physician groups, you have hospitals merging with hospitals, you have health plans buying physician groups. So you're seeing all manner of kind of consolidation now, which may be good or may not be good, and that will play out. Right. There's a cue.
There it is. Cue it up. Ed?
No, I agree with my opening statement. It's consolidation is to a reaction to the market, but if you have a monopoly, then that's not good. Then prices will increase. So I think the market, more in particular the healthcare market, has to understand that. Because I'll tell you, if prices continue to rise, the consumer will want lower prices, and government will step in, and you will see rate regulation.
You know,
it will happen.
Just to sort of give folks a bit of a benchmark, if you look at sort of cost stratified between Northern California, which as Ed was talking about is very consolidated from the provider system perspective, versus Southern California, our costs are roughly 30% higher, and it comes in two ways. It's not just unit price, so the rates that those consolidated organizations can charge the market. It's quite frankly performance as well. When I'm down in Southern California interacting with some of these organizations and you look at the performance, forget the rates they charge and we pay, the actual performance of those organizations, it is in many cases much, much, much better. And I think it's a reflection of where the North has been sort of allowed to go.
And as I said, if rates continue to go up, the consumer will demand that they be lowered, and you're going to see some kind of rate setting, and government's going to impose that upon the industry. And I don't want to see that happening. That's why I think we need to figure out how we're going to make that more efficient. And it's through transparency, through whether it's all payers database, I love your idea, but more importantly, tying the rates and the reimbursement to outcomes.
Yes.
Because what's the sense of having good rates, but you also have to good outcomes as well.
You were talking about strange bedfellows. I'd like to talk about strangest bedfellows. So instead of thinking about, we talked about innovation. And it seems like the same people, the same groups are doing the same thing, and they're embracing the status quo. So maybe because medicine is becoming an information science, we should have alliances outside what has occurred in 20th century medicine. We're in the second half of the second decade of the 21st century. So when Steve Jobs said, let's go into the music business, people thought he was crazy. But this iTunes thing, that sort of worked out pretty well. And Microsoft going into the gaming industry, that seemed to be pretty well. And even 3D printing, Nestle has an alliance with 3D printing and is now printing in chocolate. So should we be developing alliances, you could call it unholy alliances, with, we have a relationship with Walgreens, we have a relationship with Rite Aid, and I don't even think that is outstanding enough. We are working with IBM, we're working with Qualcomm, we have relationships with people and institutions and organizations that would not normally be in healthcare. And I think that tsunami of talent that's going to Silicon Alley and Silicon Beach, and instead of developing a new app for social media, if we could attract those people, those young kids, into our industry, wouldn't that be a wonderful thing for the United States?
Well, I think Covered California is looking at testing that with a new entrant to, I believe it's Oscar.
Oscar.
Oscar, and it's an app with regard to how they interact. But
Yeah.
you're going to start seeing that more and more. And in order for us to control costs, we need to be much more innovative as well.
And look, I think it's exactly right. Look outside of healthcare.
Yeah.
Look outside of healthcare. We need the best and brightest.
So one area we haven't touched on yet, we should probably spend a little time on, is innovations in drug development. It's very costly to bring a new drug to market. Some figures are as high as $2 billion. I'd say it's perhaps even more. It depends if it's stem cell based or if it's a large molecule and whether it has to be injected. But how do we make those trade-off determinations? On the one hand, we want people to get access to it, the treatments, whether it's Hep C, whatever the treatment might be, but those innovation costs are very high. And so how do we make the trade-offs between the costs and to get that innovation and getting it to patients that need it? I mean, it's a big subject, it's a separate panel, but at least ought to bring it up.
Well, the chairman of our board is here, Dr. Jonathan Thomas, who's been very much involved in the stem cell arena, obviously. Let's take one example, diabetes. We spend $24 billion in this state alone for diabetic care and all of its attributes. We now have a human trial near Scripps with a company called ViaCyte that I think is very promising, and hopefully in a few years we'll have a treatment out there for diabetes. We also know that the pancreas is going to be artificially created probably within a year. That's another element. I sit on the One Legacy board, which is the largest organ transplant foundation in the United States, and we know that pancreatic transplants are now increasing simply because of the viability of that happening. Under the initiative that was passed by the voters, Proposition 71, that created the Stem Cell Agency, it said very specifically that if a patient cannot afford the treatment, it shall be provided to that patient in California. That's going to be costly, obviously, but you have to balance the savings that you will accrue as a result of a potential cure to convince people that these treatments need to be reimbursed, because in the long term, you're going to be saving money across the board. We currently have 15 clinical trials in operation as we speak in a number of diseases. And I want to thank Michael Milken again, because Michael, I know, has been working so hard on finding cures. That's where we need to go, because that in the end is going to be less expensive than the current model which we have with Big Pharma. And that is, stem cell treatments are not part of a Big Pharma business plan. That's where cures are going to have the biggest challenge.
So Ed, I know you have a concern here.
Yes, definitely. I'd like to follow up what Art said. Yes, there's an increased cost to pharmaceutical drugs, especially what you had mentioned, Hep C, Sovaldi, et cetera. I understand that a company that does business should have a return on their investment. I understand that they have money that they put into the technology to get this medication. But I think at some point there has to be a social responsibility that they have to this country and the public as well. Give you an example. Providers, Don's group, all along the chain, we're seeing more patients and making less money. We're having lower reimbursement rate at the Medicare level, at the federal level. We're having lower reimbursement rate at the state level. And health plans with the Affordable Care Act have medical loss ratios, and they're held to standards to make sure that they return money to the consumer if they don't profit. And Covered California's goal and charge is to make sure they get the best consumer price to the patient. Okay, saying all that, but there's nothing that would limit what a pharmaceutical company could make with regards to profits. And there needs to be some checks and balances. Now, can we do it in California? No, we can't. It's obviously there's patenting issues, et cetera. But I'll give you an example. And we're talking about Sovaldi, who bought the company for $14 billion. In their first year, they made $24 to $25 billion in profit. And yes, there's a cost to the drug. It's a cost to, there's a lot of cost savings to that patient in the long term. But at what point do you have to factor out how much profit is enough? And I still think it comes down to the social responsibility of that entity. And we have to have that conversation.
You're here.
We have to have that conversation.
Yeah. So just to put things in perspective, I'm in the Jet Propulsion Lab committee at Caltech. And when we have meetings, they go, we got to take money away from healthcare. We got to send stuff to Mars. We got to send stuff to Jupiter. This medicine, if we can only get money from medicine.
Yeah.
So everybody has a big self-interest. Now, I can't imagine Bob Hugan at Celgene saying, you know, I make too much money. I think we should lower our costs.
I don't disagree with you, but but we're in a different world.
Yeah, and it feels like
We're
it's
in
sort
a
of
different world.
the last piece of healthcare that
Yes.
somehow has not given, sort of, you know, made a donation, right? And so I think I'm completely on board with Ed. I think clearly everybody acknowledges that there are research and development costs, and somehow these organizations, they've got to be financially strong, they've got to recoup those dollars. I think there is a point at which we as a country simply can't afford the way the pricing is going.
So is it back to the issue of technology tends to just drive healthcare costs higher? I mean, I've had many discussions with former heads of the CBO over the years, and that's what you hear is that technology innovation just drives costs higher.
Well, let me tell you what the Japanese are doing. They have changed their regulatory framework to allow much more accelerated acceptance of treatments and drugs. And we're fighting now, the FDA, the Stem Cell Institute is fighting, and Dr. Thomas knows this very well, that we're going to have to come to some agreement as to where these bureaucrats, as I call them,
Right. I agree.
have to be shown the light of day in terms of the regulatory framework, because that's a lot of the cost of R&D is getting through the regulatory process. So we need to find a smoother way to do that across the board. Now, what else are we facing? We're facing a shortage of clinical trial managers.
Yes.
San Francisco State, UC Santa Cruz, my old alma mater, San Jose State, are starting certification programs, but you're going to have to increase those programs, especially more bilingual clinical managers. The whole issue of technicalities and legalities, not to mention consent in terms of some of these issues, but that's a real shortage out there in terms of accelerating these pathways to cures as well as accelerating the pathway to research.
So you could have Canada, Western Europe, the United States, Australia, et cetera, have one give up sovereignty, right? You can imagine how easy that's going to be, and say if it's improved one place, it can be improved everywhere.
Well, the EU, as you well know, Michael,
and you know how well that's working out.
Right. But it is working well. I think they just started in this year in Japan, and I think, and we have a cooperative agreement with Kyoto. I believe that is the model that we need to be looking at.
Let's close on the subject. We mentioned it earlier, some of the shortages of primary care physicians, other people in the healthcare provider system. As we bring more patients covered into the covered system, it's coordinated. where are we seeing, or where are we likely to see the biggest skill shortages develop in terms of the healthcare occupational groups?
So, I mean, I think it's from A through Z. It's from primary care to specialty care. Yeah, because specialists go to large cities, more affluent communities. But I think the biggest shortage is going to be in the primary care arena. But more importantly, it's not only the shortage, but it's the distribution of where they're at. And more importantly, the patients and the patient populations that they see. And unfortunately, it still goes back to reimbursement rates. And I think it also goes back to the culture of an allopathic trained physician that wants to, they discourage primary care and they encourage specialty care.
And if you talk to any of the academic medical centers with the new rules on how many hours interns and residents can work, many of the more complex surgical procedures, when you graduate, you're not really trained, or at least the professors are saying, this guy just graduated, but he's not trained to do the procedure. So if anybody's going to have a procedure out there,
Do it now.
no. Make sure that your guys, or that whoever's doing it, has about 5 or 6 years of experience. It is generally consented that a surgeon is about the only person that finishes their training and gets more and more knowledgeable, and internists get, they start forgetting things.
Well, the dilemma that
I'm not a surgeon.
The dilemma that we have as well is our traditional ways of doing our residency programs are funded through Medicare, and that dollar is shrinking because of the Affordable Care Act. A lot of that burden is going to be shifted to the states as well, and states are suffering with the amount of revenue that they can bring in to offset those. So we have to look at innovative ways of how we do residency programs and incentivize them to go into those particular communities.
So this is a kind of a third rail issue, certainly for physicians, but a place we have to go to very quickly is the Medicare fee schedule, because so much of the spend in the United States is on seniors, and the Medicare fee schedule is important there, but it's also a benchmark for other programs and products. And under the Medicare fee schedule, specialists will make 300% of what primary care physicians make. And that has to do with a complicated method by which they determine these rates, relative value units, that's entirely skewed, owes its origins to medicine in the 1940s and has nothing to do with really the kind of population health, chronic disease world we're moving into. It will be a huge political fight, but that imbalance has to be redressed. And when that's done, in some amount of time, all of a sudden you'll get more graduates moving into primary care. Primary care is the domain for chronic disease, right? It's primary care physicians that take care of the Alzheimer's and the diabetes and so on. So we need primary care physicians. We've got to fix that fee schedule. That will be a big political fight in the years to come.
Hear, hear.
Well, let's wrap it up by a close. I could call it maybe the lightning round or the bullet point round. Let's go in reverse order. We started in alphabetical order. Let's go in reverse alphabetical order. Why don't you go ahead and tell us what bullet points do you want people to carry away from here, Art?
Primary care shortages and where they are. Nursing, we have a tremendous shortage of nurses. And I think looking much more carefully at the regulatory framework to make it more palatable and not easier, but at least more flexible. And I like the idea of maybe working with the World Bank, quite frankly, and WHO and others to develop international guidelines that maybe we can get to at least Canada and the United States, where some of our trials are going. And of course, the EU is a bigger challenge, but I think that's really the future.
Kristen?
Well, I certainly agree. We got major issues with primary care and access, but I guess what I would say is that I have been in healthcare for a long time, over 20 years, and I think the discussions that we're having right now as a country, I think the kinds of models that we're seeing crop up, I'm a little concerned that if we're not careful, it may be too little too late. But I'm really, overall, on my good days, I'm really pretty hopeful about, I think, a real transition that's happening across the country. And so I would say, I think we're moving at least in absolutely the right direction. It's incredibly complex, and we need the best and brightest to get into healthcare.
Dick, what are your takeaways? What do you want to leave them with?
I feel like a vacuum. I think cost is going to be an issue, and I think cost is going to be an increasing issue, and I don't think everybody's going to get what they want. In some countries, health is a privilege, not a right. We have to think as a country, in this country, is it a right or a privilege? In many countries, if the pharmaceutical supplies run out, they just don't get the treatment and they die. In some countries, they actually have a committee that decides which oncological drug they have, and if you happen to have the wrong cancer, you just don't get treated. That doesn't seem to be palatable in this country, and I think there's going to be an increasing tension between the cost and the revenue to pay for those treatments.
Very good. Thank you, Dick. Ed?
So I think we as a country and as a state in the healthcare have to figure out how we're going to shift from reimbursing to reimbursement for procedures to reimbursing to keeping individuals healthy, and figure out a mechanism to do that. Controlling costs is as important, if not more important, because the consumer is going to demand that. But more importantly, providers, hospitals, et cetera, have to understand that change is here and you have to adapt to it. We have to also look at consolidation and be aware of it. But more importantly, we have to make sure that this system works and that everyone is insured. And to me, it's a right.
Don, you get the last word.
So 2 points, and you made my first one, which is let's get this movement from volume to value. Let's pay the provider world's hospitals and physicians in some value-based method. I happen to prefer capitation, but there's in many ways to go. The second, and we haven't talked much about it, is there, and this is sort of the demand side of the equation, which is personal responsibility. I mean, we have in America where we have diet and exercise problems, and this is producing the huge demand. And when you add to it, as Art had pointed out, the aging population, we've got a real tsunami of demand. And this will be hard to take on, but diet's a pretty big issue, and you can see the way the lines are forming at the 7-Eleven in the morning that not everybody's eating as they should, and it's making a lot of difference. So that whole area likewise needs to be addressed, and government can do a better job in that area, in my opinion.
Great. Well, please join me in thanking our panelists. Great.
And thank you, Ross.
Thank you. It was a great session. I got to go back and look at that online now.
Okay.
Jay?
Absolutely.